not Dr. Bassman, I'm Dr. Stark, and I'm talking instead of Dr. Bassman because he's not able to be here today. So I will talk about some of my recent studies that I have done about all anticoagulation and antithrombotic medicine and resumption of antithrombotic medicine after gastrointestinal bleeding and after a traumatic injury. So basically it's among fragile patients, how we should handle these patients. So the first study is with the title called Stroke and Recurrent Hemorrhage Associated with Antithrombotic Treatment Following Gastrointestinal Bleeding in Patients with Atrial Fibrillation, a nationwide cohort study. So the aim of the study was to examine patients with atrial fibrillation treated with antithrombotic medicine and subsequently suffering from a gastrointestinal bleeding. So these patients we looked at, and this is a high-risk patient, and no randomized controlled trials has investigated how we should handle these patients after the gastrointestinal bleeding. So, but doctors are still left with the clinical dilemma whether they should restart antithrombotic medicine or not. So in other words, we need to clarify how we should handle the patients, how we should balance the risk of stroke and the risk of rebleeding after the gastrointestinal bleeding. So the final objective of the study was to examine the risk of all-cause mortality, thromboembolism, major bleeding, and recurrent gastrointestinal bleeding associated with restarting antithrombotic treatment following a gastrointestinal bleeding in antithrombotic treated patients with atrial fibrillation. And we used the Danish nationwide registries. In Denmark, all citizens are provided with a unique civil registration number. And with this number, we can cross-link information from several registries. And in this study, we used the Danish National Patient Registry. And that registry holds information about all hospitalizations. We also use the Danish National Prescription Registry, which keeps information about all filled prescriptions. And finally, we have the National Cause of Death Registry that holds information about date and cause of death. So by cross-linking the information from the registries, I was able to compute and do the data management and statistical analysis. And the study period was from 1996 until 2012. And the statistical analysis was cumulative incidences. And with that kind of analysis, we can take the risk or the competing risk into account. And also, we use time-dependent Cox regression models. And these models were adjusted for the components in the THAT-VAS score and also prior use of antiplatelets. And now the results. So we included almost 8,000 people, patients with atrial fibrillation discharged from a gastrointestinal bleeding. We excluded 3,000 patients, more than that, including those who were not treated with antithrombotic medicine before the gastrointestinal bleeding. So the final study population here comprised 5,602 patients with atrial fibrillation treated with antithrombotic medicine and suffering from a gastrointestinal bleeding. And they were included on the day of discharge from the gastrointestinal bleeding. Mean age of this population was 78 years, and 45% was female. The mean THAT-VAS score of the population was 3.6, and the mean HAS-BLED score was 2.6. So this figure is showing cumulative incidences for the whole population. And on the x-axis, we have months since gastrointestinal bleeding, and on the y-axis, the cumulative incidences. And we looked at the 4 outcomes we examined in this study. And patients who, the absolute risk of all-cause mortality was almost 40% at 2 years. And the absolute risk of major bleeding was 17.7%. 12.1% was the absolute risk of recurrent gastrointestinal bleeding. And for thromboembolism, this was 12.0%. Subsequently, we looked into restart of antithrombotic medicine. In Denmark, the average package size of antithrombotic medicine lasts for approximately 90 days. So to ensure that patients were categorized correctly into restart of antithrombotic medicine or not restart, we had to keep record of a new claim prescription within 90 days after the discharge from the gastrointestinal bleeding. 90 days after the gastrointestinal bleeding is referred to as baseline. And between discharge and baseline, we excluded patients who had had one of our outcomes in this period, which is these patients. So we have 3,409 patients we looked at starting from baseline. And we found out that approximately 60% restarted single therapy and 12% dual therapy. And we also found out that 27.1% did not resume therapy. And this is a busy slide. It's the baseline characteristics. I just want to emphasize that patients who restarted all anticoagulation as single therapy, well, the THAT-VAS score and the HASPLET score was similar to the one we found for patients who did not resume therapy. So they had a similar risk of stroke and bleeding at baseline. This figure will show the association between one of the outcomes and restart of therapy. And first, we will look at the effectiveness of restart of therapy, and later the safety of restart of therapy. And the reference group is patients who did not resume therapy. And also I have marked down here whether it favors therapy or it do not favor therapy in association with one of the outcomes. And we found that patients who resumed single oral anticoagulation, well, they had the lowest risk of all-cause mortality. And this group of patients also had the lowest risk of thromboembolism compared with patients who did not resume therapy. When we look into the safety outcomes, we found out the patients who resumed single therapy with oral anticoagulation, well, these patients, they had a statistically significant increased risk of a major bleeding. But none of the patients who resumed therapy, as seen down here, had a statistically significant increased risk of a recurrent gastrointestinal bleeding. So in conclusion of this study, patients with atrial fibrillation treated with antithrombotic therapy and subsequently suffering from a gastrointestinal bleeding. Well, the conclusions from this study are that the cumulative incidence of all-cause mortality was approximately 40% at 2 years. Also, 27.1% did not resume antithrombotic therapy after a gastrointestinal bleeding. And finally, restart of all anticoagulation was associated with the greatest effectiveness and also a relative safe use compared with non-resumption. This study has been published in BMJ in November 2015 with senior author Professor Gislason. And I welcome you to go ahead and read the paper. The other study I will talk about is a study we did after the other one, because we found out that a lot of the data regarding fragile patients with atrial fibrillation is very sparse, and we need to find out more how we should handle these patients according to how we should do the anticoagulation therapy. So the title of this study was Stroke and Bleeding Risk in Patients with Atrial Fibrillation with Resumption of All Anticoagulation Following a Traumatic Injury, a Nationwide Cohort Study. So it's very similar to the other study. Patients with atrial fibrillation were included, and these patients had to be treated with all anticoagulation and then suffering from a traumatic injury. And these patients were included, and we had to find out whether these patients benefited most from restarting all anticoagulation therapy or not. So again, how should we balance the risk of stroke and the risk of rebleeding after a traumatic injury? So the final objective of this study was to examine the risk of all-cause mortality, thromboembolism, major bleeding, and recurrent traumatic injury associated with restarting all anticoagulation treatment following a traumatic injury in anticoagulated treated patients with atrial fibrillation. And we define a traumatic injury as a traumatic brain injury, or a traumatic torso or abdominal injury, or a hip or femur fracture. We used the Danish nationwide registries again, and it was the same registries as before. And this study period was a little bit longer than before. So it was from 2000 until 2015, because we had more updated registries when we did this study. And the statistics are similar to the previous study. So 14,000 patients, 407 with atrial fibrillation were included, who had suffered from a traumatic injury, and they were included on the day of discharge. We excluded 10,000 patients and had 5,000 patients who had atrial fibrillation, were treated with all anticoagulation, and suffered from a traumatic injury. This figure shows again the cumulative incidences as the previous figure, and the risk of all-cause mortality was almost 40% at 2 years. The absolute risk of major bleeding and recurrent traumatic injury was 15% at 2 years, and the absolute risk of stroke was approximately 8% at 2 years. Also similar to the previous study, we had this 90 days blanking period, and we excluded patients who had one of the outcomes within the 90 days blanking period. So we had 3,635 patients we followed at baseline, and we found out, and we looked into whether they had resumed therapy, which was one of the NOACs, or warfarin therapy, and 25% did not resume therapy in this setting. The baseline characteristics showed that the median age was pretty much 80 years, and more women than men were included in this study, as seen here. The mean TETRAS score was pretty much 3.8, and the mean HASPET score was 2.6 among patients who did not resume therapy, and it was lower among patients who resumed therapy. So when we looked into the association between restart of all anticoagulation and one of the outcomes, we found out that compared with non-resumption, which was the reference group here as well as before, well, patients who resumed warfarin or a NOAC, well, they had a lower risk of all-cause mortality. compared with non-resumption. And also, these patients, they had a lower risk of stroke. However, this was not significant among patients who resumed the NOAC, probably due to we did not have power enough. But hopefully we will get that if we get an update. And regarding the safety outcomes, warfarin and NOAC treatment, they had an increased risk of major bleeding. But none of the groups had an increased risk of recurrent traumatic injury compared with non-resumption. So the conclusions of this study are, well, the cumulative incidence of all-cause mortality was 37% at 2 years. In total, 25% did not resume oral anticoagulation after a traumatic injury. And restart of oral anticoagulation was associated with, also in this study, the greatest effectiveness and a relative safe use. So, before I say thank you, I just want to say that some of the implications of this study are that maybe we should consider restarting oral anticoagulation in fragile patients after a traumatic injury and also after a gastrointestinal bleeding. But of course we will have to take the patient's conditions and also use the sharing decision making when we consider restart of oral anticoagulation.
Thank you very much.